Thank you for joining us this afternoon. We're very excited for today's webinar. Just a reminder, you're here with the State Performance Plan Technical Assistance Project, and this is our Disproportionality and Mental Health webinar. It's brought to you with funding from the California Department of Education through the State Performance Plan Technical Assistance Project. We're here in Napa County, the Napa County Office of Ed. My name is Connie Silva, and I'm the director of SPP-TAP. It's shorter than the long version. And today we have three wonderful guests I'm going to introduce in just a little minute. First, I want to ask you to go ahead and write in chat and let us know who you are, what agency you're with, so that we know who's with us. We have a very large group that we're expecting today. We're very excited to have everyone here. So take a moment to do that and just say hello. We know folks are still entering, so as I continue, please go ahead and just let us know that you're here. We're very, very happy to see you all. We're going to be using chat today during the session, but we do have a very full session. We're meeting for an hour and a half. We're going to make sure to leave the last 15 minutes for some question and answer, so answering your questions. So feel free to, during the session, to post your question in chat, or if you want to wait till the end, that's okay too. But at the end, we will definitely take a pause and read through some of the questions and make sure that our presenters can answer as many as we can get to, okay? So use that definitely to chat with each other as well. And if you want everyone to see the question, you do have to make sure that it's set to all panelists and participants, but we'll be able to see your questions either way. As a reminder, this webinar, like all of our SPP-TAP webinars, is being recorded. So it will be archived, and if you're here today and end up needing to leave early, we'll make sure you get the link to view it. If you're here today and are feeling badly that some of your colleagues weren't able to join you, you can share it afterwards and say, hey, it was great, you got to watch this. So just remember that will be available for all of you. So I am just real quickly going to, as quickly as I can, because I want to make sure you have time for the content, introduce our three speakers today. We have Maureen Burness, who will be moderating and giving questions to Elizabeth Estes and Alex Briscoe. I'm very, very happy to have the three of you here. This is a very timely topic, and we know that we have so many people that were interested in hearing this because we're at such a crucial point in the needs of all of our children and family right now. So let me, for a moment, just for those of you that are not familiar with our three panelists, we feel quite honored to have the three of you here, but I'm going to give brief bios for the three of them, for those of you that aren't familiar with them. So Maureen Burness is currently an SPP-TAP TA facilitator, and she's also served as the executive co-director of the statewide special education task force. And previously, she was a commissioner to the State Advisory Commission on Special Education and has led 4 different SELPAs, including forming of one as a new SELPA. She's worked with the University of California, Davis Mind to develop model programs for autism using evidence-based practices and has helped lead model sites for bilingual special education. She strongly believes in working with general education and special education as one unified system, supporting all students in a multi-tiered system of support. Maureen serves on the Advisory Council for Breaking Barriers and currently supports also the work of the California Children's Trust. Okay. Elizabeth Estes. Welcome, Elizabeth. Elizabeth is an attorney with the California education law firm Atkinson, Adelson, Loya, Rudd, and Romo. And in college, Elizabeth found herself as the victim of a violent hostage crisis that solidified her interest in education and making sure that children and families receive the services they need to stay healthy and whole. Since then, she has spent over 25 years representing school districts and dependent children and is an expert in all aspects of special education and student services. Elizabeth has been integral in training attorneys and staff across child-serving agencies statewide and has been at the forefront of developing alternative dispute resolution processes for agencies seeking to preemptively and effectively address disputes and related costs. Elizabeth is the founder of Breaking Barriers, a nonprofit working to ensure that all California children receive the services and supports necessary for them to succeed in school and society, nurtured by healthy families and strong communities. She's a frequent presenter and holds degrees from Loyola Law School and the University of California, Berkeley. Okay. and Alex Briscoe. Alex was appointed as director of the Alameda County Health Care Services Agency in 2009, where he led one of the state's largest public health services, overseeing health and hospital systems, public health, behavioral health, and environmental health departments with an annual budget of $700 million. That's a large organization. Before joining the county, he was the director of the Chapel Hayes Health Center at McClemens High School in West Oakland. That's a satellite of the outpatient center of the Children's Hospital and Research Center. Alex's work has helped design the nexus of public health and public education. He has designed and administered a number of mental health and physical health programs for medically fragile children, including home visiting programs and clinical development programs in child welfare, juvenile justice, and early childhood settings. Alex has served on the Alameda County First Five Commission, the Alameda Alliance, and the Kaiser Commission on Medicaid and the uninsured, as well as a number of other public and private boards and commissions. And he's advised on or collaborated with a number of local and national foundations, including the Atlantic Philanthropies, the Robert Wood Johnson Foundation, the Annie E. Casey Foundation, the California Endowment, and most recently with Tipping Point Community. So he's specialized in Medicaid policy and administration, emergency medical services, youth voice and crisis counseling, and safety net design and administration. Okay. So with that, you can see why we are so excited to have the three of them here today. And I'm just going to stop and pass it on to Maureen so we can hear from all of you. So welcome and thank you again.
Great, thank you very much, Connie. What I'd like to start with here is our objectives for the day. And as you can see, what we want is to help everyone understand what our mental health service needs in California schools are today. I definitely want to focus on the moral purpose in addressing that need. That is why I do this work at all. But particularly, we want to make sure that we also articulate current and potential solutions. One of the things that we discovered in putting this together is that this is a very daunting set of data. And so we wanted to make sure that you also know that we are here to talk about resources and supports and hopefully have a positive way of helping you all. So what we wanted to do from the perspective both of SPP-TAP and the Department of Education, which is the founder of the SPP-TAP contract, we wanted to make sure that you have an opportunity to discuss current issues around mental health needs in California students, but it's also about its interrelationship with disproportionality. So I think most of you who are watching are aware of the issue of disproportionality, but for a super quick definition, disproportionality is when the expected amount of any particular thing that is being measured is way different than what you would expect. So if 10% of your population is African American, but 20% of your students who are expelled are African American, you are disproportionate in that particular area. And there's many ways that our State Department measures that. So the work of the SPP-TAP is to help districts address their disproportionality once it has been identified for them. And we do that by focusing on early intervening services in what's called a CSIS plan, or a comprehensive coordinated early intervening services plan. And that's because the focus is on that earlier intervention, which is what we want to talk with you about today. So we will be sharing data with you that can sound alarming, but also make sure that we share some resources and ideas about what to do about it. We want to make sure that we address mental health in a positive way before it might become a disability, because we know that what happens is when left untreated, issues that are of emotional and mental health needs can become more problematic, even to the point of being identified as a disability for special education. So part of our goal then is helping to provide those early intervening services to help prevent that dysfunction and potential disability. So that's why we're here today. We want to talk with you about understanding that need to be proactive about addressing mental health needs, and learn about current and potential solutions, because we know that trauma is universally out there for many children, and we can address it at the tier 1 level, but we want to address it in more intensive layers as needed. So we have invited these two leaders to share some of their stories with you. You've already gotten a quick introduction of both Alex and Elizabeth as the founders of two different organizations. But I'd like to start with asking each of them to just further introduce themselves with their organizations and their purpose, just so that you know a little bit more about both Breaking Barriers and California Children's Trust. So Elizabeth, do you want to start?
I would be happy to start. I'm thrilled to be here and see so many people involved in this. So I look forward to our conversation. I am the founder of Breaking Barriers, which was really born by my experience as an attorney in California children's systems. I started as a lawyer for dependent minors in LA County, and then I transitioned to representing the public schools. And in my representation in our child serving systems, I realized that while we have child serving agencies working with children simultaneously, they aren't necessarily working together to serve the children that they are simultaneously providing resources and supports to, and that there was a very real need to have a conversation about breaking the barriers across these agencies in California and uniting resources and uniting them around the very real needs that we're trying to tackle, often at the exact same time, but not necessarily in a coordinated or an integrated fashion. So Breaking Barriers was born as a collaborative of leaders. It's largely a volunteer organization. I'm a volunteer for the organization, and we united in an effort to raise awareness regarding the need to integrate care across California's child serving systems, and to figure out ways to both have a state conversation about that and to incentivize that work at the local level. And not only to elevate the need, but to find ways to further that work both at the state and at the local level. And we'll talk a bit more about what that is. And then I'm, yes, also a lawyer for the California Public Schools right now at Atkinson.
Great, thank you, Elizabeth. And one thing that I like to emphasize is that a conversation that Elizabeth and I had about 5 years ago was just as the result of our statewide special ed task force report recommendations were coming out, which recommended one system between general education and special education. What Elizabeth said to me then was, yeah, but we need one system overall. Let's do this bigger. So that's why I've been on the advisory board ever since then. Alex, can you tell us more about you and your establishment of California Children's Trust?
Yes, thank you. Thanks for having me. Hi, Maureen. Hi, Elizabeth. It's great to be with you both. And watching everyone identify themselves in the chat is extraordinary. So thank you to everyone listening for the work you do for children. My name is Alex Briscoe, and I'm the principal at the California Children's Trust. We are an initiative, not an organization. We have a defined life cycle, and our mission is to reimagine our state's approach to supporting the social and emotional health of children. I see some familiar names, so I've worked with a number of you over a lot of years in an effort to center schools as places of healing and support. And the trust is self-consciously and directly focused on centering schools in a response at scale to something that I'll talk about in a little bit, which is something's going on with kids. If you're working in a school and you're thinking what's going on, or you're a pediatrician and you're thinking that things are different for children, you're right. I'll take you through the data. It's not just COVID. Well before COVID, young people have been telling us that it's a particularly difficult time to be a young person in this culture, and we need to rethink and reimagine how we support their social and emotional health, and schools are essential to that strategy. So I'm really grateful to be here and look forward to talking to you about it.
Thank you very much. And I'd actually like to continue with you, Alex, because you are such a great data person and we all work with our data. So I'd like it if you could present the data that you have on that persistent and growing number of children and the various behaviors and reactions that we see based on their mental health needs. And just for the bigger picture, to recognize that that disproportionality is part of the result that we see from that. But I know you have some great data to show with us.
Thanks. And I know Susan's going to be bringing this data up, but So let me just launch right in to the point I began with is the data I'm about to show you is from before COVID. So for those of you who are thinking, hey, something's going on with kids, you're right. And we call these 4 primary data points evidence of the crisis. But if you go to our website, you'll see lots more. One way to think of this data before I dig into the details is over the last 15 years, suicide has leapfrogged cancer and car wrecks as a cause of death and is now the second leading cause of death for all young people, regardless of socioeconomic status. And incredibly, in the decade before COVID, we saw a 104% increase in inpatient visits for suicide, suicidal ideation, and self-injury. One way to frame this is, what will we do as a culture when we wake up one morning and realize that twice as many of our children are trying to kill themselves? And for more than 25 years, I've worked in safety net systems. And over the last 10 years, we've actually shown a dramatic ability to reduce length of stay, meaning the numbers of days patients spend in the hospital. So across all disease burdens, we have reduced length of stay by almost 30%, with the exception of pediatric mental health. Between 2006 and 2014, it was up 50%. It's up another 15%. And when we asked young people directly through the California Healthy Kids Survey, they were self-reported a 61% increase in mental health needs. So not only were they telling us, our young people telling us by their self-injury rates, their morbidity factors, but also they were telling us with their words that they needed more and different. And unfortunately, our progressive state ranks 43rd in screening and actually 44th in mental health access for children in Medicaid. And before we go to the next slide, I have to ask everybody who's listening, and I know there's hundreds of you, I need to ask you to do something we call the suspension of disbelief, because I'm going to dig into Medi-Cal, and I know that's a bad word in education circles. So I need to ask you to think therapeutically for a second and imagine your problem is the pathway to your solution. So hold 1 second, because remember, the vast majority of the kids you serve, the vast majority of kids in special education are uniquely and newly eligible for Medicaid. Next slide, please. But as we know, you can't look at this data if you don't disaggregate for race. 81% of children in Medicaid are Black and brown or are non-white. And the suicide rate for Black children is twice that of white children. And 70% of children in detention meet 1 or more diagnostic criteria. We can't address disproportionality simply by focusing on economic status. Something is happening with children, and we could literally chop it up all day long. Is it 2009 when social media became available on mobile platforms? Is it a news cycle that's perpetual and is insensitive to the developmental status of children? Is it 400 years of structural racism? Is it the stabilization of poverty that 7 or even 8 out of 10 children born into poverty never get out? And the answer is, it's all of those things. It's a witch's brew of public perception of culture and circumstance that has created a uniquely difficult environment for children to grow and thrive. And I know you know this because you're on the front lines of it. Next slide, please. Unfortunately, while the striking increases in utilization acuity have plagued both our schools and our health system, we have done less and less for kids. What's called the penetration rate, which is a terrible term that we use in Medicaid, but it's an absolutely horrible term. But what it refers to is the number of kids on Medicaid, 6 million of California's 10 million kids who touch the system at all. Believe it or not, that penetration rate has actually dropped during these increases in utilization and acuity. And the number of kids who are in ongoing care, as measured by 5 or more visits in a calendar year, is now down to 3%. And when you constrain access in any system, you push utilization to the higher cost crisis systems. And you're seeing a 20% increase in crisis service utilization across our system. Next slide. We all pay a price. Behavioral health is the leading cause of disease burden in America. We lose more money and productivity and human potential to behavioral health conditions than any other disease burden, spending billions. And maybe most importantly for you on the call today, 37% of students with a mental illness over 14 drop out of high school. That's the leading disability factor that drives high school failure. And we all know that untreated behavioral health needs can lead to lifelong challenges, not only in social and emotional development, but in academic achievement and social mobility. But as you can certainly infer from what I'm saying, it's not like all of a sudden twice as many kids got pathological. Something is happening in our culture that is driving social and emotional dislocation. And it's not strict or traditional mental illness. If I spontaneously combust, if you remember nothing else about what I say today, I hope you will hear in my comments a strong and direct affirmation that mental health is not a response to pathology. It is a support for healthy development. In fact, the history of Medicaid tells us so. It suggests that all children need things, not because they're sick, but because by doing them, we prevent future illness. Thus, we do immunizations. We can think of mental health the same way. In other words, we need the revenue from the health system without the medical model. We need the medical model as money, but not their focus on pathology. Next slide, please. COVID is obviously pouring gasoline on the fire. You can click through the next 4, please. It exacerbates the equity gap. It creates a massive disruption in children's routines. We know the link between economic security and isolation, not only domestic violence, but self-injury and suicide rates. We have proven this over more than 150 years of research. We know that economic insecurity drives mental health disorders. And maybe, poorly understood, as poorly as we do as a healthcare system in supporting our partners in education and leveraging schools as a source of care, when you close schools, you actually turn the spigot off more than 50% of all the existing mental health services, about $2 billion worth of services. So we've been in a hustle over the last 8 months to shift those services to remote modalities. But destabilizing the provider network, and you know what these are either you as clinicians who can't access your kids because they're not at school, or providers like Hathaway Sycamores or Seneca or East Bay Agency for Children, or other community-based organizations that take contracts to co-locate at your school. Next slide. Our awesome Surgeon General, you can go ahead and flip through these, thanks. Next slide. Nadine Burke-Harris is showing us that when you close schools, you disrupt almost half of all mental health services. We will not know for decades the impact of social distancing on the social and emotional health of children. And maybe this is, I'll conclude with this last point. We often talk about fragmentation in child serving systems. And please, I have actually delivered mental health services in every child serving system, in the regional center, in juvenile justice, in foster care, in public education, in the emergency department, in the inpatient setting, in ambulatory care. I've billed Medicaid and provided mental health services in all of those settings. And we often talk about fragmentation by system, education, juvenile justice, child welfare. What is poorly understood is the vertical fragmentation that COVID is also exacerbating. By that, I mean the disconnect between the federal government, the state government, the county government, the school, and the provider. This fragmentation creates this illusion of resources that when you actually get to the school site and the life of children and family means they get very little. So in theory, there's a federal benefit that says kids get everything they need to thrive. The state will tell you that they're in compliance. The county will tell you services are available. But you and I know when you get down into the lives of low-income children, there's very little. In fact, one accurate way to describe our mental health system is most kids get nothing, and those who do get the wrong kind too late. And recent studies show it's only getting worse. We are seeing never before levels of expression. 1 in 4 young people ages 18 to 24 said they've seriously considered suicide. And we are failing as a state. It's a collective failure. So when I say this, I'm not pointing the finger at any school district employee or any health director or any governor. We have collectively failed morally, administratively, and fiscally to center the lives of vulnerable children and to begin to flip to a hopeful frame. If you're not depressed, you haven't been listening. But what I would like to suggest to you is we actually have shown a willingness as a state and as a broader culture in times of crisis to center the lives of children. And I believe we are at the cusp of doing something like that right now. Remember, we expanded health insurance for children called SCHIP to Reagan and Bush. We can do stuff. The problems facing our children, we made them, we can unmake them. Next slide, please. Experts we all respect, including Nadine Burke-Harris, our awesome new Surgeon General, George Everly at Johns Hopkins, Dr. Sandra Galea at BU, they're all telling us that we will not know for a long time what this means. And so for all of you who've been working in schools and who knew well before COVID, right, well before COVID, that young people were experiencing social and emotional dislocation at unprecedented levels, and schools were essential to any response at scale, I think we now have a universal national consensus. If anyone can possibly still argue that your context doesn't impact your social and emotional welfare, they don't have kids. All of us with children are worried about what the current context is doing to the social and emotional health of our children, and experts are confirming it. Next slide, please. So I'm going to actually, in 30 seconds or less, so stop right there, please. Hold on 1 second. Yeah, right there. I am going to, in 30 seconds or less, break down Medicaid for you. So take a deep breath, because this is the 30 seconds where I'm going to ask you to flip from thinking about Medicaid as something that's a problem, as something that could be a solution if we only have the will and creativity to see it that way. So one way to think of California's Medicaid program is like a shriveled Charlie Brown Christmas tree with a bunch of pretty Christmas tree ornaments on it. To understand Medicaid, you have to think of it like a pot of gold in DC. If you put up $1, you get $1. Every Medicaid expenditure is part green dollar on this slide, a federal dollar. A state or local dollar activates it, and then it gets spread through these 7 intermediaries before it shows up in the lives of a child or family. So I'm going to do this one more time. This is how Medicaid, known in California as Medi-Cal, created in 1965 under the Social Security Act. This is how it functions in California. And you can legitimately say, when 7 people are responsible for an entitlement, nobody is, and you would be right. One of the major challenges we have with Medi-Cal in California is that there's so many different people mucking around with it that nobody does it well. The federal government matches with the state dollar, and it distributes through these 7 mechanisms. The key one for you to know as schools that you currently don't interact with is actually the biggest one. Health plans, or what we might call managed care organizations, have become the dominant player in California's safety net systems. In 1996, 10% of children were enrolled in a managed care plan in Medicaid. Today, 90% are. So one thing you can do as school district leaders is understand the managed care landscape in your county. Every county has a different one. Some of them, like Sacramento, there's 6 private plans that all have a little piece of the business. Some counties, like San Mateo, there's 1 plan called a county organized health system. Many counties have 2 plans, like LA Care and HealthNet, or the Alameda Alliance and Anthem, or the San Francisco Health Plan and Anthem. Those are called 2-plan counties. It's essential for school leaders to begin to understand the managed care landscape. The next biggest would be the county mental health departments. That's who you currently interact with most. School districts also have their own direct billing option, which has recently, as of June, been expanded. So for those of you who have historically been afraid of those LEA billing option program paperwork burden, guess what? More's coming your way. Because we changed the LEA program to not just be eligible for kids with an IEP. Now the LEA billing option program is open to anyone in Medicaid across your entire school population. So we expanded just from the 772,000 kids with an IEP to all children in general education who are on Medicaid. This will create some new billing opportunities and also some new paperwork for you if you're a school district employee. And then finally, there's community health centers, co-located FQHCs. We did a lot of this in Alameda County. LA is doing some, and there's about 300 of them statewide. They're super important, but they work best in higher volume, meaning higher population, more kids enrolled, and mostly in middle schools and high schools. Next slide. So I'm going to end on this slide because you can find out all about how Medicaid works from the perspective of a school district administrator or staff member, and what I'm about to say in something called the Practical Guide for Mental Health in Schools. You can get it on our website. I think the link, it just was put in the link. It has a very kind of brief description of Medicaid, and then it goes through these 5 models I'm about to name. And I would encourage you, if I've whetted your appetite at all for Medicaid, then read that doc, because we did it with Breaking Barriers. It's a collaboration among some of the leading thinkers in the state, and we tried to distill a pretty complex set of problems. But remember, in the previous slide, I showed you there were 7 different payers for Medicaid. School districts are learning how to navigate this complex environment. In fact, there's some extraordinary work going on. And in each of these 5 models, we list an example. The first model is school districts are increasingly contracting directly with mental health plans and managed care organizations directly. The model we highlight is Los Angeles Unified School District, who has some extraordinary leadership. They have one of the largest LEA BOP programs, and you can see details in the guide about exactly how they're organized in approaching this problem. They also have lots of contracts with providers, so none of the models that I'm suggesting here are mutually exclusive, but it's important for you to know, kind of make the market. How are school districts organizing with those 7 payers? The first model is school districts are doing it themselves, establishing contracts and hiring staff. The second model is SELPAs, like Desert Valley, are creating consolidated models that serve multiple partner schools. Desert Valley is doing some of it, San Mateo is doing some of it. Really, this is an example where we're leveraging the historical role of Medicaid in special education and trying to expand and export it to general education as well. The next model is the most common model, and this is a model where a community-based organization signs an MOU with the school, but contracts directly with the county mental health plan, sometimes the managed care organization. And this model is actually about 60–70% of all Medicaid services in schools are delivered through this type of partnership. And the reason this is so popular is it's a way for school district staff and administration to outsource the administrative burden of interacting with those payers. And there's a very good reason for this, is that it's hard, it's difficult, there's audit risk. So there's a reason this has become the dominant theme. And frankly, most school districts will expand in some form of partnership, either by creating their own depth and capacity, like LA is doing, or by expanding their partnerships with community-based organizations. Next slide. Some counties, in fact, the only county that I'm really aware of doing this is Monterey and Alameda County, where the county health department formally creates an intermediary to serve all of the school districts in its catchment area. Monterey is doing it, Alameda County did it. I don't know that there's other county health authorities taking this on, particularly in this economic climate, but those are 2 specific examples. We highlight them in the guide. And finally, and perhaps most excitingly, county offices of education are stepping into this space between the school and those 7 payers. Examples include Sacramento is launching their new program right now. Fresno has over 100 therapists. Contra Costa and others, Santa Clara, are all looking at playing this role of standing between the complex Medicaid payer universe and school sites by holding contracts with those payers, hiring staff, and co-locating them in schools. So let me close here with a final comment. If you remember what I said about Medicaid, it's like a pot of gold sitting in DC. You put up $1 to get $1. And you also maybe remember from the beginning of my presentation, I said California ranks 44th in the nation in spending and access for children. But we also have the 4th highest non-federal tax base. So if you understood me about Medicaid, you see the opportunity I'm naming. We actually have the dollars to match. We haven't matched them. Examples of unmatched eligible non-federal dollars include Prop 63, Prop 64, Prop 10, fines and forfeitures, tobacco taxes, and yes, even local control funding formula. There are opportunities before us to expand the pot of Medicaid without spending more money, simply by pulling down a federal match on the dollars we are currently spending. So hint, hint, nudge, nudge. Not only is there a crisis, not only do we have to acknowledge the centricity of race and class in the formation of that crisis, but we do have a solution. Almost 6 out of 10 kids are now eligible for Medicaid, and we can claim the federal dollar if we but have the will and skill. Thank you.
Thank you, Alex. We do actually have multiple things that we want to talk about as well. And we were concerned about this amount of data scaring people because it is in fact depressing. And what we know is that children have these adverse childhood education experiences. And so what I wanted to ask Elizabeth about is, how is she seeing that? Elizabeth, how are you seeing this show up in schools? And what are some of the things, the very positive things that you've seen schools do to start to address that in the meantime?
I would say that this epidemic, I consider an epidemic, is what started me talking about breaking the barriers to care across our child serving agencies. It's showing up. I mean, everybody who has logged in here knows how it's showing up in our schools. There isn't one school district administrator, staff, teacher that hasn't commented in the years. I've been representing education for 21 years. In the past 5 to 6 years, that hasn't commented on the striking social, emotional, behavioral health needs that are presenting themselves on our campuses in our schools, and the complete overwhelm with relation to what we are trying to address in the schools, and the lack of infrastructure and resources to do that. And Alex has just highlighted for us, and we ended up meeting, Alex and I, through my digging on these issues, frankly, over the years, and Alex being such an amazing behavioral health partner and someone who has come from that world to say, we do need to partner and we do need to match these dollars and we do need to put these resources in the schools. And I just cannot, every time I speak, I can't thank him enough for being someone who was willing to do that. So I think it's presenting itself on every single campus. There isn't a person who isn't seeing this very significant need showing up, and also in disproportionate ways with a very significant impact on certain populations of children. And I don't believe that we can address disproportionality in a vacuum. I don't believe any one siloed agency can do that. So this work is critical to us reaching those goals.
Great, thank you. What you have done is get us to my next question, which has to do with moral purpose, as if people don't already understand that. But if you could each take a moment to just talk about what you see as the moral purpose in addressing these needs for our children, for our families. And so what are your hopes and dreams about what this renewed focus and these efforts can do to be of greater service to our children and families?
Well, obviously, I like to care about things, but it's not hard to care about this issue. And I think, frankly, we as a culture need to heal. We need something to come together around. And we have shown a history and willingness to do so around the suffering of children. And I also think there's some truth that we can confront as a culture when we unpack what is going on with our kids. And that's a little bit of the point I was trying to make, not a little bit, the central point I was trying to make is kids did not become pathological on us. Our culture is making kids sick. Like, you have to acknowledge that. And we need to move away from a healthcare system that pathologizes them. Because I have literally billed hundreds of millions of dollars of Medicaid in just about every clinical setting you could possibly name. The vast majority, 80, 90% of the kids I served weren't mentally ill, though I had to diagnose them to get paid. One way to kind of sum up the reform agenda we have at the Trust is we absolutely believe you must remove diagnosis as a prerequisite for care. It is the symbol of breaking the medical model that is imprisoning our mental health system in a day late and a dollar short and make $1 billion short. We have to actually create a mental health system that reflects the things that are driving children's social and emotional dislocation. And that is our own cultural moral failure, a history of structural racism, a lack of investment in children, a loss of social mobility, and an epidemic of hopelessness that is showing up in the behavior of children. I'll stop there.
Right, and Elizabeth?
I don't think that we can talk about an equitable world without talking about this. I don't think that any one of us in any one of the child serving systems that Alex has worked in and built in is going to be able to reach the goals that we collectively want for all of the children and families of California without tackling this work together. And without caring about it, without making that very intentional decision to make this a priority. And when Alex says, you know, we haven't prioritized children, we haven't prioritized children in our systems of care in California in the ways that we need to. And we have to. There are economic papers on the reasons why we need to be doing this in California. We need our children to reach the goals that they want for themselves and that we want for them, for California to be the state that we want it to be in the future. We will not reach that goal. Dow Myers at USC wrote a brilliant economic paper on why we need to be all hands on deck for the children of California in a whole child effort to serve them. And I agree also that this needs to be prevention work. And Alex has operated in a world where, you know, you have to diagnose to treat. And in education, we talk about our tier 1 and our tier 2 interventions, you know, in advance of special education eligibility. But the reality is many children don't receive those supports and interventions because our systems aren't aligned to build that robust continuum yet. We're going to get there. And so then they fall in to special education, or, you know, people talk about the wait to fail system. We're still wait to fail in ways I think that if we do this work, we can address. So I think it's probably the work that we all need to be doing now.
Right, and that's exactly why I was happy to do this with the two of you, and because I believe so strongly in all of that as well. I do think our democracy depends on our doing a better job. So thank you both. Let us move on to a focus on progress and some examples of some positive efforts, because I know that you both are involved in many of them. And together, and Alex, you mentioned this, the California Children's Trust and Breaking Barriers, for example, both collaboratively worked on the practical guide that you referenced, but there's also been multiple things that you've done in schools, talks, webinars, the practical guide, various consultation. So Alex, will you start with this one and tell us some of the specific supports that you and California Children's Trust are offering to schools? And certainly using the practical guide as an example of how to serve children.
Yeah, so you got to hit this issue top down and bottom up. So we have to reform Medicaid, meaning grow the pot, remove diagnosis, expand the provider class, right? Devolve access, use care coordination, case management, and social models far more aggressively. But then we also have to engage with you in the education space and grow your sophistication so you can navigate the complex environment I began to describe today. What I can say is it can be done. And I don't always like doing this example because folks think that because I'm saying it means everyone can do it. No, but in Alameda County, between 2004 and 2014, we grew school-based mental health programs in over 227 sites. We added almost 9,000 kids to care, and we spent $110 million new dollars. But that's just one example. Fresno told us on the phone last week that they have placed their 105th clinician in the school districts that the County Office of Ed serves. I know that Los Angeles Unified School District has just entered contractual relationships with their Department of Mental Health for a community schools initiative. Desert Valley braided funding from multiple ways in their SELPA to provide services and supports to, I can't remember how many of their participating school districts. And there are numerous other examples, including really incredibly creative new models emerging in Sacramento and in Santa Clara. So first I would say is, it is super complex. Don't believe the hype. I once had a mentor say to me, someone who can't explain something to you either doesn't understand it or is trying to get over on you. So what I would strongly suggest to all of you is one of the most important things we can do is learn Medicaid. It's many faces. its historical underpinnings, the reality is that you don't have to have a diagnosis for Medicaid to pay. An immunization, you don't have to have measles to get immunized. That's the same benefit that covers mental health. The dropping in of 17 diagnostic criteria to define medical necessity, that was a decision the state made in a waiver in 1984 that narrowed access to protect its budget. We all need to know that page 23 of the 1915B waiver must be reformed. So if you have nothing else, I would recommend learn it, understand it, be difficult trouble. All of the kids in your school are federally entitled to a set of services they're not getting. Learn who's responsible for doing it, and in love and kindness, partner with them and be difficult.
Sound like John Lewis for us. Thanks. So Elizabeth, can you please add your perspective about breaking barriers and the work that you are doing collaboratively? And one example that I know we both worked with was the Mental Health Services Act, the Oversight and Accountability Commission, and the contracts with different systems of care in school districts. That's one example, but you've also talked about a hub for integrated care in the state and various other pilots. So what would you like to focus on sharing with our group here?
So we started this as a very organic conversation. As an attorney in the children's system, I knew that these children had entitlements, which is what Alex is talking about, that were not being provided to them across our child serving systems. Their entitlements to services under Medicaid and Medi-Cal are actual entitlements, like the IDEA is an entitlement. They can't be capped and can't be limited. And that we in education needed to educate ourselves about those entitlements and to become advocates for those entitlements for the children and youth that we're serving, which I think is a big piece of what Alex is suggesting. If I was sitting in an IEP team meeting early on and breaking barriers, and I had a child who I knew was Medi-Cal eligible, I would start asking questions about, what other services are they receiving within the county from the mental health plan or the other providers. And a lot of times my clients would look at me and say, why are you asking that question? Well, that question is incredibly relevant to the robust service delivery system that child is eligible for. So some of the work that we've been doing in breaking barriers at the state level originally and into the past 5 years has been to say to the state, we need to integrate, we need to join the agencies that serve children together in the care of children with shared goals and shared outcomes and shared accountability and shared information. And it's a red herring to say that can't be done. And that resulted with the Mental Health Services Commission in what is now known as the Mental Health Student Services Act, which is a number of grants that many of you probably have that launched, we've started like 4 years ago, and now we have over 20 counties, I think, in receipt of these, but to incentivize education and behavioral health to become partners in programming to expand services on school district, behavioral health services on school district campuses, and the continuum. So that's consistent work that we are still involved in tracking, as well as the system of care, AB 2083 work in California, which requires each county to have an interagency MOU. And everyone should know that we do have that obligation in California, and that memorandum of understanding can be utilized to create shared governance at the local level. And there is a technical assistance team in Sacramento who provides support for that work. We have been running the symposium. This will be our 5th year for anyone who's interested. It will be a deep dive into shared governance, shared information, shared financing. Alex will be presenting a deep dive into the financing guide, and shared community, having our community partners be as integral to the continuum as we are. So we will be doing that, our 5th soon. And then, yes, Maureen just mentioned, I've become a very strong advocate for some sort of state technical assistance around integration of care, school behavioral health partnerships, but even beyond that, to the partnerships with the other agencies that we serve with, like child welfare and probation. I pick up cases. My expertise for the public schools is children who touch multiple systems. And I still pick up cases every day in different counties where it's our agencies that are in a dispute over who's going to do what, or kicking the can over who's going to do what, where we really should be united in understanding how we're going to collectively serve children that we serve simultaneously, but not necessarily together. So all of that work is happening.
So I wanted to do a little more focus on the Breaking Barriers convening, or the symposium that's coming up, because one of the things that has happened over the last few years has been the opportunity for sharing things that are going well and various partnerships across systems, as we invite people to come in teams or as the grantees to those mental health services awards. So there's a lot of great information about ways that schools can and have been doing incredible work across agencies. So do you want more time to focus on what this particular next convening, because it's coming right up, what it is that you'll be covering in that deep dive?
Well, I think we've put the agenda out, I believe, to everyone. So you can see all of the presenters that are talking about those 4 pillars. I think the deep dive sessions, and one Alex will be doing on the practical guide, is really an opportunity to do a deep dive. And I would encourage you, if you're going to participate, to participate. The symposium was designed in order to bring partners together at the symposium so that you can hear information about how to move your collective service delivery systems together, and then to have conversations about how you're going to do that in your local community or in your county. So I would encourage you to invite your partners. But Alex is going to spend an hour going through the practical guide. And so, if he's piqued your interest at all, as he had mine, and I've spent a lot of hours with Alex, so it takes a lot to learn this, but you can do it. I mean, I guess my biggest message for today is this work can be done. It's very doable. There are many, many people who've said to me over 5 years, it can't be done. There's this, HIPAA and FERPA, there's information, there are all these, and those are, yes, all of those laws exist, but none of them are actual barriers that we can't overcome to doing the work, and that people aren't overcoming. So.
Great, thank you. Alex, I'm going to read this question to you just because of its complexity, and because I think you've addressed a lot of the pieces to it. So maybe you can just pull out what you still might want to say about it. So you've talked about this guide addressing Medi-Cal and how to better access it. But can you expand on how a change in systems processing will encourage access to more and more students over time through this expanded Medi-Cal process, especially as Elizabeth was just talking about, in conjunction with expanded community partnership options, and especially in this time of pandemic-induced crisis, which has just added that incredibly difficult, more extreme layer to all this work we're doing?
Well, I was acknowledging how great a question was, and then lost my train of thought. Can you
So it was about expanding on how you think this change in systems processing will, how the change will encourage access for more and more students, and especially with community partnerships and because of the pandemic.
Yeah, I mean, there's no way to ignore the fact that we have to spend more money. So, like, to begin with, like, I can't help but notice in the chat
I know.
all these great points that are going on. Like, all of us who've worked with kids have all said at some point, if you're really in trouble, get a lawyer and get an IEP. Because, frankly, all the other systems will push a kid around, except for schools, which actually take their entitlement seriously. And I saw a great comment in the chat, whether you're rich or poor and you're in special ed, we're going to try to get you what you need. And that ethos needs to be exported to Medicaid. Unfortunately, it's an ethos that only exists and very, very uniquely exists in special education. And it's causing this huge financial burden. That's actually the ball and chain of public education financing, is the dramatic expansion of up to $15 billion will be spent this year on 772,000 kids. It's sucking the lifeblood out of our school district budgets. And so much of that is Medicaid. So to answer your question directly, Maureen, if we are able to both change how we claim non-federal dollars so we can grow the pot and reform the benefits so you don't need a diagnosis, so that you can do more stuff with extenders like peer-to-peer folks, social models, case management, because there's a lot of mental health that can be done with appropriately trained adult allies. They don't all have to have a master's degree or a PhD or an MD. There's really important work that can be done that extends the clinical frame using non-clinical extenders. And we must change the benefit design so that it not only pays for that, it encourages it. Because no legitimate analysis of our current workforce gets us to scale. It's not just money, it's that there aren't the people to pay. School district staff here, I'm sure, are aware of the challenge of trying to hire licensed staff. California Healthcare Foundation has a great analysis of it. So if we're able to grow the pot and redefine the benefit, we can lift the burden on special education, reinvest in public education, create schools as centers of healing and support, not just for children, but for their families and the adults that work in them. So at the heart of this kind of financy stuff and benefit design stuff I'm talking about is a simple premise that schools can and must be centers of healing. And that doesn't mean that teachers and principals have to become doctors and therapists. It means that our public health systems must align and formally support this evolution of schools into a new role and function.
To acknowledge the pandemic and the fact that that has changed everybody's lives recently here, and it has changed and exacerbated mental health issues for so many of our children and their families. So what is it that you think we need to do differently, if anything, now, given all of these new circumstances?
I'm just going to go right at the Medicaid enrollment piece, right? The pandemic is disproportionately impacting poor people of color, like almost every other bad thing in our culture. And those are kids. Like, kids are Black and brown in California. Like, poor kids are Black and brown. So the pandemic is disproportionately impacting the working poor, driving more and more families into housing instability and wage insecurity. This means the Medicaid rolls will grow. So you're in a circumstance right now where 6 out of 10 kids in the state are on Medicaid. That's probably 7 or even 8 out of 10 kids in public education. You can legitimately see a future within a year where fully 8 out of 10 children in California's public schools are eligible for Medicaid. So the pandemic is this incredible burden that is showing the world what happens when you are isolated. We all acknowledge that our isolation is impacting our social and emotional welfare. And now we are creating a pathway for payment if we reimagine schools as a place where that service happens. And I'll make a final comment here about the nexus of health and education. Education has to think differently about what they do, but health actually has a problem. Children 8 to 18 have the lowest rate of primary care utilization of any demographic group in the Medicaid program, meaning they go to the doctor the least. Well, 75% of mental illness manifests between 8 and 18. Just when you need the healthcare system the most, it's not there. Schools must be reimagined and redesigned as the mental health clinic of the future, because that's where kids are. And that's where the only place to legitimately and potentially serve them is. And Medicaid is obviously the dominant payer.
Great. Elizabeth, you and I have talked about this a lot. What do you think we need to be doing differently now beyond the Medicaid question in a more integrated system of care?
We need to be doing this Medicaid work, obviously, and bringing these services into the schools. But what I'm struck by is I helped deconstruct, however many school districts across the state of California. We represent about a third of California school districts. And so when we all went to shelter in place, we had to, as we all know, begin providing services in a totally different way through distance. And now we're coming back. And in the 26 years I've been in the child serving system in California, we have never been in the position that we're in, where we have changed how our services and supports are being delivered and our systems, and we're in the position to put it all back together in the next couple of years here. And I would encourage us to do that in a way that incorporates this work, as well as all of the other work that we're going to be doing as we're bringing children back to campuses. As we are reopening schools, let's not reopen schools in the silos that we have been operating in with the penetration rate Alex just cited. Let's reopen schools with these partners at the table in order to build a more robust continuum. And I guess I would just add that, as Alex says, like this work has to happen in the schools, and we pay a greater price economically as a state. We all know this, by not doing the prevention work. Because when the services, when the child's needs become more severe and the family's needs become more severe, it is more costly to the state in the end not to do this prevention work. And I think we need to be talking about that.
I would agree. And there's a lot of comments in the chat about the need for social emotional learning supports from day one. And some great examples that I've heard recently are even just family check-ins as part of the distance learning with a question about, well, why don't we just do this anyway? So I do think we have an opportunity to do some rethinking here.
The other thing, Maureen, I would add is we've never had relationships with, the county departments of public health and health like we have now. I mean, we are in the same boat right now, figuring out where we lie in different tiers and, how we're going to reopen our schools. And we need to take that opportunity to be having these conversations. And at the symposium, I will say, for whoever presents on whichever aspect of this work, everyone is more than willing to follow up and share and have a conversation with someone in the field who's thinking, how do I go about doing this work? How do I even begin? Everyone who will present is someone who has said to us, we will be more than happy to talk about doing the work we did, replicating the work we did, moving this needle forward. It's a really incredible group of people committed to this effort, including Alex.
Great, thank you. I want to remember that this is being hosted by the Significant Disproportionality Project. And one of the things that our project has done is we focus on helping districts identify the root causes of their disproportionality from a systems perspective. And you have both discussed several possibilities that districts might be able to do to change or whatever from a systems perspective. So my question for you each is, what is your advice for the top 3 things districts can do immediately to help address the disproportionality we see in mental health needs across our student populations? Alex, you want to start with that one?
Yeah. So first is, it could be a broken record, learning the medical system in California. 1. Second, take advantage of the things that you can do for no money and no cost. Specifically, all of us know a positive school culture when we walk on a campus, because it's almost always being held by students. And there are an extraordinarily large number of low-cost, awesome things that can be done in high schools with peer health education program, with little kids with tribes and other kind of models like that. Basically, there are things that can be done to build a pro-social school culture, call them bottom of the pyramid, whatever term you want to use, where you make the school healing centered and you invest in people solving their own problems. You don't treat them as empty vessels, but as opportunities to spread their wisdom and beauty to each other. And then finally, I think the third most critical thing, after first learn Medicaid and do the things I said earlier. Second, invest in peer-to-peer and other social model programs that don't cost anything. The third is adults need to build a culture of healing among themselves on a school campus and a school culture. I've told this joke lots of times that Maureen and Elizabeth have heard, but just a few weeks ago at my own dinner table, my high school senior daughter who's going off to UC, and my incoming freshman son, my son said to my daughter, what's the secret to high school? And my daughter said, I don't know, to my son. It's a bunch of adults telling you to treat each other the way they don't treat themselves. And her point was that often in schools, we don't do the work of creating healing-centered relationships adult to adult. We don't learn the name of each other's children. We don't understand the racial and ethnic diversity among us as staff members that is beautiful and should be celebrated. We don't take the time to learn and hold each other's beauty and wisdom. This can be done cheaply. And in fact, the school psychologists and school administrators who have dominated I know the attendees today, these are things that you can lead at little to no cost, that are nothing about billing Medicaid or nothing about navigating the complex landscape of Medicaid. They're about using the birthright we all have as individuals to treat each other well and have that be reflected in every interaction, not just in what we tell kids to do.
Great, thank you. Elizabeth, how about you? What are your top 3 things to recommend?
I would say go to the practical guide and digest it. We were very intentional about bringing, Alex's expertise in the financing of this, along with strategies to do the work, like 5 steps to approach the work and how to go about doing this work. And I think that both are critically important. So I would say do that. Build a stakeholder group at your local level to start to have this conversation, to do this work. I mean, I tell a lot of my clients, even when we're building, and Maureen and I have talked about this, even when you're building your LCAP, we have community partners that are supposed to be, engaged and involved at the table, as well as, of course, our parents and children that we serve. And so bringing them to the table, even when we're in the development of that, I think can be really helpful. Identifying your entire continuum is one of the first things that we put in the guide, and figuring out where the gaps are in that continuum, and then having your partners with you build out that continuum. And as Alex is saying, at tier 1, that development can be, without any additional cost. So being very intentional about building an integrated system, I think is one of the first things that we can be doing. And like I said, and I started with this, I have doubts that we in silos in our child serving agencies can address the disproportionality that we're seeing. We need each other to do that.
Absolutely. Well, thank you both. I know there's a lot of questions in chat, but I want to make sure, do you have any final words of advice or other issues that people should consider as they're making their plans for improvement or reinventing how it is that they're going to be tackling things as they reopen?
There's a lot in the chat about needing more infrastructure and support to take the time to do this work. And I think that's right. I think it's intentional work, but it also is not embedded in many people's day-to-day right now. And so I think becoming advocates for the state, making allocations for us to have staff at schools that are dedicated to doing this work is something that we should be talking about right now. So yeah, I guess I would add that. I've certainly become an advocate for that.
Mm-hmm. Alex, any last words of advice?
Yeah, my counsel, because it's a lot to hold. Like, I just took you back to 1965, right? And I just showed you this incredibly complex way that $100 billion flows in our state. Unfortunately, very little of it to children and families. So my suggestion is to start at the beginning. Learn your student body. Who are they? What programs do they qualify? And learn the context they live in. What health plans serve them? Who's the county mental health director? Who's the child welfare director? So it's a combination of understanding who your children are by socioeconomic status, by income level, the systems they live in, and the resources that those systems tap. And this is really important. Most child-serving systems are purchasers, not providers. This is really important to hold, you guys. Meaning they contract most of their services to community-based organizations. In every school community, there's a community mental health provider. There's a local community health center. There's an after-school program or provider. Part of this journey begins with simply mapping what is out there to know and hold. This is, I think, the great contribution of the community schools movement, is to think of our work outside the walls of our school and learn the world that our children and families interact with and mine it for opportunity and potential. So while you're learning your kids, while you're learning the systems they interact with, the resources that may or may not be available to them, you will inevitably grow the depth of your understanding of these child-serving systems and the actors in them, because those are the people you got to get in partnership with.
Great. I can't thank you both so very much. That this was absolutely fabulous. My job was going to be to reinforce the moral purpose and the need, but I don't think I need to reinforce it, because I think you both gave us a lot of information that says the need is there. We all know the need is there. We know we need to address it. So thank you for that. But also for the hope about ways to begin to address it. And there are a lot of different ways and different things we can do. Definitely focusing on recommendations about bringing in more money to the system to be able to support that. But also practical things like reinforcing how is this going to work with your LCAP. Sorry about my phone here. I'll just. So we do want to make sure that we're doing the best that we can in all the ways that we have it. But I know we have lots and lots of questions, and we were promised 15 minutes at the end to be able to try to address those. Frankly, I don't know if it's Susan or Jen who's going to try to, there's a lot of questions in there. So hopefully you have been monitoring that closely for us to be able to tell us what are the priority areas we should try to address.
Thanks, Maureen. I think I'm going to start from one of the most recent ones. There's a lot of great conversations happening in chat, so some really aren't so much questions, but there's a lot of dialogue going back and forth. So if you've had a chance to look through that, it's some great work going on in there. But one of the last questions I think I saw is, who do we need to advocate to in the move away from diagnosis for service? Is that state or federal representatives or both?
Yeah, I saw that question. So thank you, whoever, I think it was Juliana, whoever picked it up, because that's so great. To me, that says you were listening. So it makes me feel good. Thank you so much. So we've actually had a really big win on this already. If you remember the 7 intermediaries, and the biggest one was the managed care organizations, the health plans. We literally just got a benefit approved in July called the family therapy benefit, which removed diagnosis for the first time in the history of Medicaid for the first 5 visits. And then after 5 visits, any qualifying ACEs score justifies ongoing support. And it's the expanded definition of ACEs, including the original 10 plus housing insecurity and an experience of racial discrimination. So literally in July, for the first time ever, the biggest payer gave us a pathway. Now, the problem is that payer is the one who's most absent in schools. So the least relevant as it currently stands to schools. So we have to activate them. And not to go too far down this pathway, but those managed care plans have only had a mental health benefit since 2015. Until 2015, the only place to get mental health reimbursement was through your county mental health plan. That's called the carve-out. In 2015, health plans got something called the mild to moderate benefit. And it has grown dramatically. There's over 110,000 kids who get a service through it now, but almost none on school campuses. So that's why I kind of hammer away on the importance of the managed care plan as a future payer for services in schools. So your question was who to advocate to. Advocate with us. So first of all, join the coalition at the Trust, just sign up, doesn't cost anything. We won't try to raise no money from you, but join us and track our work as we do this. It must be done to both the state Department of Healthcare Services, the state Health and Human Services, and the governor's office. All 3 have to be won over. It does not have to be done at the federal level. The definition of medical necessity is something done in your state plan, so it is fully within our control. The challenge is the financing one, is that the state will say anything that opens up the funnel is going to cost more money, and that's going to be a fight we have to have.
In my work on the ground, and expanding continuums with health partners, some of the health partners in some of the counties, both the MHPs and the MCOs, have been willing to come to the table to talk to a school team about how they can build a more robust continuum on the school campuses, and to utilize some of their dollars, whether it might only be community benefits dollars, but utilize some of their dollars, and then some of those partnerships, at least now, are having discussions about education becoming one of the billing, entities for the MHPs and the MCOs. So reach out, as Alex said, and keep asking questions. I literally spent years saying, you need to tell me more. How do I know? How do I understand this better? Wait, what's an MHP? What's an MCO? What's the difference? We do need to educate ourselves.
And if I could just make a couple comments, because I'm watching the chat, and I want to be super clear. Until 60 days ago, whether you were getting a mental health service paid for by the county mental health plan or the managed care organization, the health plan, you had to meet diagnostic criteria, one of 12 or more qualifying conditions. Just 60 days ago, the managed care organizations approved a new benefit for the first time that allows some kids to get services without a diagnosis. It's the first chink in the armor, first crack. But for all of you asking in the chat, so for Jody, for Drew, for Elizabeth, for Doreen and others, no, this kind of handcuffs on our mental health system, which is that you must meet diagnostic criteria before you qualify for services, is still the primary truth. It must be destroyed. And there's a crack in the armor with the health plans who will allow a little bit now. We got to drive a truck through that little crack. So Stacy asked, who are some kids? Currently, the way this family therapy benefit works is you have to be identified in primary care. And then you have to be referred to the therapists who are what are called on panel for a health plan. We're going to be doing some work about teaching schools and community-based organizations about how health plans work. So join us at the Trust, and you'll see some trainings coming up in November about kind of how to learn how to crack the code with managed care organizations. The name of the benefit in July is called the Family Therapy Benefit. I will send the PDF of the provider manual or a link to the benefit to the organizers today so they can send it out.
Thank you. So then we have some other questions. So many rural areas or smaller districts are having trouble getting the partner departments to assist or participate. What can they do to get real partnerships?
I'm happy to riff on that, Elizabeth, but if you have a comment, please do.
Go ahead, Alex. Alex would have been your partner. Go ahead. I have some thoughts, but go ahead.
Yeah. So first is, unfortunately, it's only going to get harder in the short term. County mental health departments rely on vehicle license fees and sales tax for their revenue. So think new cars in the mall. And they are seeing significant declines in their base revenue. So new partnerships with county mental health plans, regardless of their willingness, are going to be extremely difficult in the short term. So just, our safety net is funded cyclically with the economy. When the economy is doing good, there's more resources available. When the economy is doing bad, there's less. Just when you need it most, the safety net gets frayed. So partnerships with county mental health plans and child serving agencies are going to be extremely hard. That's one of the reasons I'm nudging towards the managed care organizations, which are less exposed fiscally to economic downturns. They get paid through something called capitation, which doesn't shrink even when the economy goes down. So your question was how to generate authentic reimbursement, authentic partnership. And like any good therapist, the only answer to that is human relationship.
Right.
Burn somebody's name, call them up, invite them to your school. Don't tell them they suck in the first call.
Yeah.
like, I don't know how to say it, love them up, be kind, talk about the needs of your children, show that you understand who the kids are in your school and what they need, and see what they might be able to do. Sorry, that feels inadequate, but that's really what there is right now.
I think it's important. Alex was mentioning the low penetration rate in the state of California on access to what is an entitlement for children. And Alex, I'd be curious to hear your thoughts on this, but one of my thoughts as an attorney for the children of California is that's a very real legal entitlement that they hold that is not being offered to them. And it should be. And the burden of that sometimes, if not all the time, is borne by education, who has those children in their schools, and yet they don't have that robust continuum available to them. So I do feel like everyone who's I've ever spoken to about this has said relationships and reaching out are critical, and that things are possible that we do not think are possible if we do that. And that's certainly been my experience in breaking barriers and in my work on the ground with the schools. But I also think being aware of the numbers in your county, where your Mental Health Services Act dollars are being utilized, how much of that is being utilized for children? What is the penetration rate on EPSDT in your county? Understanding that when you're having your conversation where someone says it's impossible for us to do more, I think is important.
I saw a question from a small county. I think it was Kings County. The question was, is there something we can do so that us in Little Kings County, but you're huge in every other way, could reach out to Fresno or Tulare? So yes, there are partnerships across county mental health plans that are super interesting, but there are also, what I would say to Kings County is find out who your Medi-Cal managed care organization is. It might be partnership. I'm not sure who it is. I could look it up for you, but and I would start there. I would call the health plan and ask, what, if any, opportunity that would there be for us to partner for services on that school site?
And they also are left in a position many times now with this epidemic, with seeing children in emergency rooms and the multiple 5150 calls that we're making, and children cycling through, what is more intensive need and care. And I think having a conversation with them about that prevention work is really important too.
Yeah.
And yes, the other counties that Alex mentions, and they're all in the guide, like there are actual concrete examples of these counties in the guide that are doing this work. And they're all, I know pretty much everyone in there is more than happy to have a conversation about what they're doing.
Great. Thank you both. Jen, are there other questions that we need to cover in our last few minutes?
Yeah, I have a couple, hopefully we can get through. One of them, so all this information resources we've been provided, is there anyone at the district who should be learning this info? Is there like one person or position or role?
Yes, generally there is a director of student services or student health services director. The larger districts have a dedicated function on this work. So the answer is, in the larger districts, the director of student services or the director of health services is the essential actor at the district level. But I need to add, at the school site level, there's lots that can and should be done. Whether you're a school psychologist or a school counselor or a school administrator, still learning and mapping the local system for your children, I think it has to be done school site by school site. I don't think that can be skipped.
Yeah, we put that in the guide, but I think for me, it's less working with so many school districts. It's less the who, which title holds this work, but there should be people that are dedicated to doing this work and doing this analysis and outreach. And in the absence of that, we're too busy doing, all of the other things that we're doing. And somebody was mentioning special education as sort of, the starting point for all students. And I have to tell you, I have landed on that even myself. we take our special education population and really think about the multiple entitlements that those children hold and a prevention model in a full continuum for them, we could change outcomes for those children, and we could change financing. We could change a lot.
And that's why I would add that typically the CBO and the superintendent should know about these things, because having been a director of student support services, if you don't have the administrative support from your board and your superintendent to go down a path, and they don't understand the need and the potential of it, it's a much harder job than if they do get that. So particularly the CBO, who runs with numbers all the time to figure out how are we going to do this? Well, here's a solution for you. Let's work on it.
Well, and I think we need to become advocates for our children. We need to become advocates for their multiple entitlements and for doing this work.
Right. Because of the moral purpose, after all.
Well, I saw Adriana Herrera put an extraordinary quote from someone who's a favorite of mine as well, Dr. Bruce Parrish, Child Trauma Academy. And the quote that she put in the chat, which is super beautiful, is that the more healthy relationships your child has, the more likely he or she will be able to recover from trauma and thrive. Relationships are the agents of change, and the most powerful therapy is human love. There are lots of ways we can be engaged in relationship with children differently and in more healthy ways. And so you don't need Medicaid to simply begin to examine the depth and nature of the relationships that children have in schools. It doesn't always have to be a relationship with a therapist, though that's an important one.
That's a beautiful note to end on. Thank you, Alex. And thank you for the person who put that in the quote. I was reading that one as well. Again, I just want to thank everyone, obviously, who attended and who took the time today to listen to what Alex and Elizabeth and Maureen had to share with us. And especially also to Alex and Elizabeth and Maureen for sharing a lot of really good information today. And I do hope people will take advantage of digging more into the guide and also attending the Breaking Barriers, where they can definitely hear more. But again, thank you, everyone. And if you have further questions for us, feel free to reach out and we can certainly connect you. And I know that both Elizabeth and Alex would be happy to have more conversation and hope to see you guys at their event. Okay. All right. Thank you, everyone. Now, thank you.
You're the ones making the difference, by the way.
That's right. That's right.
That's
Thank you.